Good evening, everyone. In the next few moments, I would like to present my progress about my thesis entitled Optimization of Acute Pancreatitis Management. But first, let me introduce myself. My name is Patoni Cristina. I am a resident in gastroenterology. I started my PhD last year in Bucharest, and this year I'm part of the translational medicine program with a scholarship offered by MOL Group. My supervisors this year are Dr. Balinteros and Dr. Hegi Piterieno. My vision regarding acute pancreatitis is that we can decrease mortality and complications by improving the management, so my mission is to fill the gaps in the guidelines. For this, I would like to answer two relevant clinical questions. I will start with our first project entitled Anticoagulants Decrease Mortality and Major Complication Rates in Moderately Severe and Severe Acute Pancreatitis. Currently, the manuscript was sent for the internal review, and we plan to submit it to gastroenterology. We all know that acute pancreatitis is an inflammatory disease, and as a consequence, it is associated with vascular injury, activation of coagulation, and increased leukocyte rolling. There is a close relationship between the thromboembolic events and the severity, and this is due to the close relationship of the large mesenteric vessels to the pancreas, to the hypovolemia, and to the prolonged immobilization of these patients during the hospitalization. Although anticoagulants are frequently prescribed in clinical practice, there are no specific recommendations for this in our current guidelines. Moreover, besides the anticoagulant effect, heparins have shown to have the ability to regulate inflammation and to reduce the digestive enzymes, and by this they reduce the severity. So our aim is to assess the safety and the efficacy of anticoagulant therapy in the treatment of acute pancreatitis. For this, we use the PICO framework, and our hypothesis is that they reduce, that they improve the outcomes, and they are safe. The search was performed on 14 October. Our analysis, our search key retrieved a total of almost 8,000 articles, from which we included 7 in the meta-analysis and 8 in the systematic review. Now let's move forward to our results. I will start with mortality, which is the hardest outcome that we could evaluate. The population included for this outcome is mainly by patients with moderately severe and severe acute pancreatitis, and 6 out of the 7 studies included reported the use of low molecular weight therapy as anticoagulant. As you can see, all studies revealed similar results. Respectively, there is a benefit from the additional anticoagulant treatment in acute pancreatitis. However, we still have a moderate heterogeneity, which is due to the study of Kroner that included older population. For these patients, we don't know the distribution of the severity, neither the type of anticoagulant they used. Our study, our analysis revealed that mortality is decreased by half in the anticoagulant group in comparison with the control. Moreover, we were able to perform subgroup analysis only for RCTs that bring the highest level of evidence, and they revealed that anticoagulants lead to a 76% decrease in mortality rates with statistically significant results. Highly related to mortality is the multiple organ failure. In the RCT subgroup, we see again similar results, low heterogeneity, and they revealed that incidence of multiple organ failure is decreased with 67% in the anticoagulant group. Among the organ failure, we are able to perform an analysis only for acute kidney injury, although it included only 3 studies. It revealed that anticoagulants are associated with a lower rate of acute kidney injury in around 10%. Another outcome we were able to perform analysis was the need for endoscopic or surgical intervention. Again, most of the studies report similar results, And in the RCT subgroup, we can see that by adding anticoagulant treatment, mortality, the need for further intervention is reduced by half. We also performed subgroups for severity. Due to the lack of time, I didn't include these plots here, but I would like to emphasize their results. Respectively, there is a benefit from early treatment in the course of the disease. Regarding the length of hospital stay, our analysis revealed that it is shorter with around 5 days in the anticoagulant group compared to the control. I would like to emphasize the strengths and the limitations. We have several strengths. We have the highest level of evidence because we were able to perform subgroup analysis for all the outcomes. The total number of patients for all outcomes are more than 200. We have low heterogeneity for the RCT subgroups, and we used robust methodology. And of course, this is the first meta-analysis for assessing the safety and the efficacy of anticoagulant treatment in moderately severe and severe cases. We also have some limitations because of the low amount of data in the subgroup analysis, because of the low reporting of the safety outcomes, especially the bleeding, and we performed the publication bias, but it's not reliable since we have less than 10 studies included. In conclusion, our analysis revealed anticoagulants reduced mortality and major complication rates. In acute pancreatitis, early initiation of treatment has enhancing benefits, and further studies are needed to assess the safety. Regarding the implication for practice, adding anticoagulant treatment is beneficial for moderately severe and severe acute pancreatitis, and the implication for research, we should further assess the benefits of anticoagulants in mild pancreatitis and to report the safety outcomes and the laboratory parameters. I will move to the second project entitled Safety of Early versus Late Endoscopic or Percutaneous Interventions in Infected Necrotizing Pancreatitis. I would introduce you briefly this topic. Acute pancreatitis necrosis occurs in 5–10% of all cases of acute pancreatitis, and infection occurs in 40–70% of patients. Since the introduction of the step-up approach, regarding timing, the optimal timing for the intervention, it is not assessed. So, on one hand, we have the European guideline that recommend first intervention should be performed delayed after 4 weeks, and on the other hand, we have the American guidelines that recommend intervention should be done after 2 weeks for patients that have infection of the collection or they are symptomatic. For this, we used as well the PICO framework. Our hypothesis is that postponed intervention are safer than early intervention in infected necrotizing pancreatitis. The search was performed on 5 databases at the end of March. It included 3 concepts, first regarding acute pancreatitis, the second regarding the necrosis, and the last for the collections. This is the flowchart of our selection. After the duplication removal, we had more than 10,000 articles, and we included 68 for the full text review. This is a quick overview of my 2 projects, and in the end, I would like to thank you for your attention, and I would like to end my presentation with a quote for Vincent van Gogh: "Great things are done by a series of small things brought together."
Thank you, Cristina, for your presentation. Maybe I missed, but do you plan to do subgroups for those? Do you have the data for that? Of the dose of anticoagulants in your first meta-analysis?
Thank you for your question. Indeed, this is an important aspect. We try to perform subgroups regarding the dose. We divided our articles in two groups, prophylactic dose and the therapeutic dose. Our analysis revealed that there is a slight difference between them, so we might conclude that patients could receive a prophylactic dose of anticoagulants for acute pancreatitis.
Thank you for your presentation. I would like to ask whether did they, in the articles, did they wrote if there was any risk factors of thromboembolic thrombosis in these cases, not just the pancreatitis?
No, they don't report this as an exclusion criteria if this is the main question. They don't say nothing about thromboembolic events.
My question regarding your first project, what kind of controls do you have? Any major differences that would contribute to the results?
Well, in the control group, patients received only the standard of care, which is mainly based on fluid therapy, pain prevention, and of course, intensive care measures if necessary. There is no difference between the controls, so that's all.
Okay, thank you.
May I ask that did you exclude the mild acute pancreatitis cases? Only the moderate and severe cases were analyzed because you concluded that it has a beneficial effect in moderate and severe acute pancreatitis?
No, we didn't exclude them. We wanted to include all types, all stages of acute pancreatitis. Only that we didn't find data in the literature, so we only performed subgroups for moderate and for severe cases because of the lack of data.
For the mild cases,
yes.
That's why you concluded that only moderate and severe. Okay, thank you.